Hi guys, in this video we're going to go through a case of acute appendicitis. And this is a case from learnabdominal.com, a website made by Dr. Michael Hartung. I'll sort of walk you guys through how I approach a case that I see in the emergency department. So some people like to follow their search pattern no matter what. So let's say, for example, someone comes into the emergency department with right lower quadrant pain. They order a CT for suspected appendicitis. Some people would, start with the liver, gallbladder, pancreas, spleen, adrenals, kidney, follow the ureter down, and then follow the bowel up. Some people like to do that approach. The approach I like to do is that if it's a suspected case of appendicitis, then I would first look at the appendix and complications of appendicitis, and then I would follow my search pattern at the end. The reason I do that is because let's say the pathology is down in the appendix, and I start with the liver, and then I'm looking at my liver, spleen, pancreas, kidneys, gallbladder, and just following down. It may be 4 or 5 minutes later that I finally come to the appendix, and by the time I'm tired, my concentration and my acuity is high in the beginning and it sort of falls down. So I want to provide the maximum attention to the pathology that's already suspected. So let's say it's just a case of abdominal pain, the ED doesn't really have a strong idea what may be happening. Then the way I approach it is that I scroll down, um, taking 15-20 seconds, and I look at every organ just a single time. So at the level of the lungs, I would put it on lung window. I didn't see a big mass, pneumonia, pleural effusion. And then I go down. Here at the level of the liver, I stop once. At the level of the pancreas, here it's kind of hard to tell because the posterior wall of the stomach and pancreas, but at least whatever I can see in the pancreas, I didn't see anything bad. Then I'll stop at the level of the gallbladder. Again, it looks pretty unremarkable. I'll stop at the level of the kidneys to see if there's a big stone or hydronephrosis. And then I go down and then I look on the right lower quadrant in the general area of the appendix. Sometimes just trying to find appendix can take me a few minutes. In this case, I do see something that alerts me. For example, um, on I told in my previous video that most lateral and posterior wall of the abdominal cavity, usually it would be the ascending or descending colon. So if you look at the descending colon right here, the wall is thin and there's nothing behind. In our ascending colon, we do have contrast, but there's something thick behind, something around, which could be an appendix. So I look in this area and then I go down and I look in the pelvis for ascites. So in this case, we do have ascites here. So this is female, this is her uterus. And we do have ascites. So once I go down like this, so I know that the area that I need to pay attention is this general area because I noticed something abnormal. So let's see. So I have something long and tubular right here. It seems like an appendix. There's something bright, which I would suspect is appendicular. Let's try to follow it to see if I can track it down to the cecum. And if I follow it down, it is a little bit hard. And let me window it slightly differently. But if I follow it down right here, I think I can probably track it down as coming out from the cecum from right this point. So I'm pretty convinced this is a case of appendicitis. Let me look at it in coronal. Again, something long tubular with appendicular length comes down here and seems to originate from the cecum right around here. Let's look at it in sagittal. Hold on, try to find it. Where was it? I'm on the wrong side. So this is the side of the liver. So here I have something long and tubular with something dense that I think is appendicular length, and I can follow it down as coming from the cecum roughly around here. So this is appendicitis. Now let's try to find complications. So let's see if we see a focal discontinuity on the wall, which we always don't see. That would alert that this is a perforated appendicitis. So I can follow the wall of the appendix pretty well all around. I didn't see any focal discontinuity that tells me that there's perforation. Now, one of the other thing that any inflammation in the bowel, we use this term dirty fat, which is, let's look at the fat here, let's look at the fat here. Around the appendix, it's just thickened. So anytime you're trying to find something inflammatory going in abdomen pelvis, inflammation causes swelling. Swelling means there's water. Water is more dense than fat. So you see inflammatory stranding. So there's inflammatory stranding around the appendix. Do I see a round collection that would tell me that maybe there's a developing abscess? Nothing really. I think this is just thickened, inflammatory tissue around the appendix, but I didn't see something round, loculated that would tell me that that's an abscess. There is some ascites here, which I think is just reactive, and you guys may have noticed this round structure and this round structure. These two are just ovaries. This is some prominent follicles in the ovaries, and usually as long as it's less than 3 centimeter, we tend to not call them cysts. So these are just ovaries. Then the other thing I would look in case of any infection, inflammation is that are the vessels patent. So there's our portal vein, left branch of portal vein, right branch of portal vein, coming down to the superior mesenteric vein. Let's just see if I see any obvious thrombosis of the superior mesenteric vein. No, I don't see it. I didn't see it. Let's follow my IVC right here. My common iliac vein, my external iliac. Again, the contrast opacification is pretty poor, but I didn't see anything that would tell me that there's thrombosis of the vein. So let's follow on this side. It looks pretty good. And then the other thing I like to look at is that if there's perforation of the appendicitis, which is what I'm looking for, is I'm looking for free air. So let me take it to long window. So my appendix was around here. See how easy it is to see air. This is just air inside the ascending colon, but I didn't see any air around the appendix that would tell me that, hey, there's perforation going on. But I would sort of scroll from bottom up. So this is just air inside the bowel. Again, air inside the bowel. Do I see a free air inside the bowel too? This one is a little concerning. Let's go back to the soft tissue window. Hard to tell, but probably still inside the bowel. Let's go up. Again, all I see is air inside the bowel. Do I see air outside the bowel? I don't see it. So this case, there's acute appendicitis. I don't see a periappendiceal abscess. I see some free fluid in the pelvis, which is just most likely reactive ascites, and I didn't see free air. So that's the summary. Now I follow my search pattern. So I go down, look at the liver in more detail, gallbladder in more detail, spleen in more detail, my pancreas, my adrenals, my kidneys, follow the ureters down. In this case, it's pretty hard to follow the ureter. This lady is pretty skinny, but I lose my ureter around here. But if I look at it coronally, I didn't see a hydronephrosis. So I'd follow it down, I would look at the bladder, the uterus, the ovaries, you looked at them already, and then come back up, um, go to the coronal, look at the aorta and the branches, look for lymphadenopathy, um, look for the bones, the soft tissues, and also follow the bowel. So let's quickly follow the bowel in this case. So here's our rectum. There's stool, a lot of it. So see how tortuous this sigmoid colon can be. So from our rectum here, it comes up here. I think it goes here, here, and probably this way. And I think it comes up and goes this way, goes up, and then comes back down again. So this is the transverse colon, like the ascending colon goes up and the transverse colon is sort of dripping down. So from here, let's see. Here, here, and then here, and then let's try to find my terminal ileum. I think my terminal ileum is coming here. So this is the terminal ileum going into the cecum. And we can follow the ball. Antegrade fasten from the esophagus. There's my stomach. There's some food in the stomach. And probably here is where my duodenum starts. And then let's go down, and then I want to see the duodenum pass in between the aorta and the superior mesenteric artery, and I think right here is where it passes. So even though it's kind of hard to see, we can kind of make it that the duodenum goes out this way, our jejunum on this side, our ileum on this side. And yeah, that's the case. Thanks for watching.